Okay, hello. So my name is Jamie O'Halloran. I'm a PhD student from the University of Southern Denmark. And I'm going to be presenting my fourth paper of my thesis entitled Going the Extra Mile, Physicians Upcoding of Fees for Home Visits. I'm supervised by Dorte Good Hansen and Sofie Oksel, my new Bjørnskov Pets. So, GPs, well, physicians and GPs are typically paid through systems which rely on them self-reporting their performances or activities that they've conducted. The health payer is typically unable to observe the actions of the physician, these information asymmetries between the information asymmetries between the physician and patient and health payer gives the potential for GPs to game the system as to maximize their own revenues. This type of behavior is typically hard to uncover. There is evidence of it primarily within the hospital sector with the DRG creep. However, there does exist some evidence within the primary care setting, but the evidence is rather limited. So we have two main aims of this paper. The first aim is to investigate whether there's evidence of upcoding of home visits, and whether the prevalence of upcoding depends upon the value of the upcoding. We are interested in home visits for two main reasons. The first reason is that GPs self-report which home visit band they provided to. So GPs, home visits the distances are based upon travel distance from the GP practice to the patient. Then there are different fees based upon how far away the visit is. So the smallest home visit is less than 5 kilometers, then goes to 5 kilometers and all the way up to 21 plus kilometers. And then another interesting facet for home visits is that there's quite a large fee increase which affected the fees for home visits in 2018. So prior to the fee increase in 2017, we see that the value of upcoding is reasonably stable at around 5 euros, whereas after the fee increase, we can see actually the value of upcoding is nonlinear, where such that there's a variation in the value of upcoding after the fee change. So in the 5 to 8 kilometer, we can see it's around 18 euros, whereas in the 17 to 20 kilometer, it's around 47 euros. So if you upcode from 17 kilometer home visit to a 21 plus kilometer home visit, you gain 47 euros, which is not a small amount, not a small amount of money. So, as I said, the correct band is the correct distance is based upon the travel distance from the GP practice to the patient. So what we measured the distance from each GP practice to each patient using using a mapping software in R, and then we use this to then define whether the home visit was upcoded or not. So we define a home visit to be upcoded if the billed distance is greater than the actual distance. So if a GP traveled 4 kilometers but billed for 5, we would find that this home visit will be upcoded. And then we find that we provide evidence of upcoding by investigating if the prevalence of upcoding is greater than that of downcoding. So downcoding is the opposite of upcoding. So the GP bills less than he traveled. So if he traveled 5 kilometers but billed for 4, this will be a downcoded home visit. We assume this to be measurement error, as there's no financial incentive for GPs to do this. So we then test whether more of these home visits are upcoded than downcoded. If that is the case, then we would indicate that this is evidence of upcoding. We do this in this table. So we do a number of a series of proportions tests that indicate whether the prevalence of upcoding is greater than that of downcoding across each of the bands. I've just shown for all home visits in this table here. We see that around 11% of all home visits are upcoded, whereas around 3 to 4% are all downcoded across our whole sample. We then find that this prevalence is statistically significant, indicating that there is a higher prevalence of upcoding than downcoding. So we indicate this is evidence of upcoding of home visits. This is then true for all distance bands as well, that I haven't shown. Right, and then the second question that we were wanting to investigate is to investigate whether the prevalence of upcoding depends upon the value of upcoding. You would have thought that the higher value of upcoding, the more likely it is to occur. And we do this by using linear probability models with GP fixed effects, with the outcome being a binary variable indicating whether it was upcoded or not. So in the first column we see in the first column we look at whether the prevalence of the downcoding is greater after the fee change. So after 2018, we do find a significant and negative difference between after the fee change. So after the fee change, there's a reduction in the likelihood of upcoding by 0.05%. So a very small difference, but though it is still negative. We also conduct a series of robustness checks. The first check here is that we allow for a 1 kilometer discrepancy. So we allow prior to the fee increase, we saw that if you build a 4 kilometer home visit as a 5 kilometer home visit, that would be found to be upcoded. However, now we give GPs this additional one kilometer, so that visit will now be labeled as a correct home visit. This is because we don't know exactly which route each GP took to get to the patient. So it could be the case that due to some sort of congestion that they changed from the quickest route to another route. So this tries to account for some of this uncertainty. And we can also see that it is still negative and significant and of similar size. The next model seeks to exploit the value of upcoding after the fee change. So the fee change dummy is still negative and significant. And we then interact this dummy with each of the bands. It is important to remember that the 9 to 12 kilometer home visit is the one which is the least valuable one to upcode at around €9 after the fee change. And we do find it's a significant and negative reduction in the likelihood of upcoding by around 2%. And then the 5 to 8 kilometer, we also see it's significant at around the 10% level, at a reduction of about 1%. Then when we come down to the larger bands, so this is the 21 kilometer plus, we actually find a positive effect of the likelihood of upcoding. So after the fee change, they are more likely to upcode these 21 kilometer plus home visits by around 7%. I think this is an interesting finding. So we firstly find evidence of upcoding irrespective of the fee change. However, after the fee change, we find that there was a reduction in the total level of upcoding, but we do find that actually in the larger bands, we do find a slight increase in the prevalence of upcoding. I think this is an important result for a policymaker. We also estimate the cost of the upcoding to the health payer. We find that prior to the fee increase from around 15 to 17, the value of upcoding was around €80,000 a year, which corresponds to about 1% of the total cost of home visits. Whereas after the fee change, it increases to around €300,000 a year, which is about a 3% cost, which corresponds to 3% of the total cost of home visits. These numbers are reasonably small. However, a policymaker may wish to create a system which measures the distance from each patient, enabling GPs to now upcode any more home visits, as this is an unnecessary cost. Thank you.